some of the latest guidance actually that's come out of the European Vascular Society with the management of both chronic and superficial venous disease. And it has really been quite a challenge for many years of what to do. And I'm going to give 3 cases. The first case is a 67-year-old lady who came to our clinic in April of this year. You can see an ulcer that's on the gaiter region of the leg, very classical appearance, clearly some skin changes before, and some early ulcerative changes that started to break up in the skin. The next patient is a 35-year-old man. He was newly diagnosed with type 2 diabetes, had a DVT in August of 2020 around the COVID time, and this was a distal DVT, or 𝗙𝗋𝗋 DVT, sorry, proximal DVT, but infrainguinal. And he presented to our clinic in January of this year, just after his honeymoon. The third case is a 55-year-old lady who has had multiple DVTs in the past and has been afflicted by recurrent ulceration for many, many years before coming to see us. She is otherwise well, ambulatory actually, but is understandably very much saddened by her venous ulceration. So clearly, priority number 1 is to get compression therapy in. And I don't think that anybody would disagree that compression should be given to all patients with a suspected venous leg ulcer who has good arterial disease. We know from trials like this, the 𝗓𝘀 trial that was published in The Lancet in 2014, that 70% of patients, if treated early, can get good healing. And it costs a relatively modest sum of £2,500. But even in the UK, where we have a good primary care setup, it's hard to do. And I don't know what it's like in Egypt, but 80% of patients still struggle to get good compression bandaging regularly. So this is a great situation, but it's very ideal. Nevertheless, it's priority number 1. But what can we do? So patients present with leg ulcers. We need to make sure that they don't have any arterial disease. We get them into compression therapy, but then we need to see them. And that's priority 2. See the patient early. Once we've got an established leg ulcer, if we can treat them early, you will get better results. Of course, the next problem now is what to do when we see them. Priority number 3, get a proper venous duplex. Regardless of all of the cross-sectional imaging, venography, intravascular ultrasound scan, I still believe that ultrasonography is the first and hallmark investigation to do to try and understand both the superficial and deep venous disease. Of course, there are limitations, but a proper venous duplex, both on the arterial and venous side, to be honest, is very informative of how you might manage this patient. And so far, I don't think that any other imaging technique has superseded this. So priority 3, get a venous duplex scan. Now, we've all been very excited by the 𝗟vra trial. This was a great trial done by 𝗏𝗀𝗆𝗆 and Alan Davis in the UK. It really sort of confirmed what we were already doing, which is treating superficial venous reflux. You know, if you can get the treatments done early, you can improve ulcer healing. And you know, without question, it has really given the evidence to continue our practice. But the reality is that in this trial, 6,500 people were screened for eligibility, and only 450 went into the randomization. The vast majority of patients were excluded. And they were excluded for reasons of having ulceration for a long period of time, which is very common, for having other reasons, including deep venous insufficiency. So while we say that superficial venous disease and treating superficial disease is very important, which I totally accept, we must be very understanding that the real world practice is that it's a lot more complex than this, and just treating superficial venous disease is not the only answer. So priority number 4 is to understand the etiology. When we look at patients who have venous ulceration, actually nearly half of them have some form of deep venous disease, either reflux or obstruction. Another 20% have both deep and superficial disease, and another smaller percentage also have perforatory involvement. Only 1 in 5 of patients have just superficial disease alone, and so it's very important in the 4th priority to try and classify exactly where the pattern of disease is, because that will help really drive your treatments. And it's this point where I would consider cross-sectional imaging, either with CT venography, direct or indirect, but in my practice it would tend to be magnetic resonance to understand the etiology. And here you can see a patient who's got an IVC thrombosis, a chronic IVC thrombus. You can see here lots of collaterals around the side, no real IVC, and this patient has been going through compression bandage after compression bandage for 5 or 6 years until he came to see us. And then priority 5 is to treat the pathology, and this is the guidance from the European Society with patients with symptomatic chronic venuses. And by symptomatic, I do mean venous ulcers. So really, when we're thinking about this, the 3 things that we want to look at are, is there an obstructive lesion? If there is an obstructive lesion, where is that obstructive lesion? Is it suprainguinal or infrainguinal? Is there deep venous reflux in the popliteal veins? Is it also associated with superficial reflux? If it is with superficial reflux, treat the superficial reflux. So patients who have deep venous reflux, almost that can be ignored, because even if you do treat the superficial reflux, about half of those patients will have improvement of their deep venous reflux. So treat the superficial venous reflux even if there is deep venous reflux present. And then it's this more challenging group, combined obstruction with reflux. So if they have an obstructive lesion and also superficial venous reflux, what should you do? My preference is generally to treat the obstruction first, but with an addition of that, then I would also treat the superficial venous reflux probably about a year afterwards. And if they fail to respond, only then would I consider doing anything else in terms of valvular incompetence. And in the 5 years that I've been practicing this sort of treatment algorithm, I've treated no valves at all, and we've got very good ulcer healing rates of 85%. When I do talk about interventional treatment, however, I think something needs to be really importantly recognized, that this is the iliofemoral region. So fempopliteal regions, or fempopliteal obstructions, I rarely treat at all, and I think this is largely experimental, using things like the Access PTS type of trials, or putting patients into new trials. For example, we have a bullfrog trial that's running at the moment. So in the iliac region, that's the obstruction that I would treat. In the fempop lesion, I would leave them alone at the moment. So what did I do? So this is a 67-year-old lady. She had her ulcer in March of 2022, significant GSV reflux, as well as deep venous reflux. For me, this patient went on to have RFA ablation. Note it was about 2 months later. That's as quick as we could try and get that done in our system. But I'm pleased to say that she had a very good response. Within 8 weeks, her ulcer was healed. In this 35-year-old man who was diagnosed with his type 2, he had no arterial lesions at all. He presented again to us in January. His duplex showed that he had fempopliteal occlusion, no more proximal occlusion than that, and GSV reflux. He again had radiofrequency ablation in May 2022, and this is most recent healing in September of this year. And you can see there are still lesions that are there, but at least he's progressing into treatment in a nice way. Our third lady, who came to us in 2019, she was clearly post-thrombotic, had multiple episodes of DVTs in the past, otherwise well. She's had cross-sectional imaging which has confirmed an iliac occlusion as well as significant GSV reflux. For her, we placed a venous stent in on this leg, and a year later, after the ulcer had healed, I treated the GSV, and it's remained ulcer-free now for going on 4 years. And this is her ulcer now, most recently. So what are my 5 priorities? Number 1, compression. This is still the first line thing to do for all patients with a suspected venous leg ulcer with normal arterial patterns of flow. Number 2, see the patient early. If you can see them early, you're going to get better results. Number 3, organize a venous duplex, because that is still the best first line imaging to get no matter what we have right now. And 4, understand the pathology, because if we can understand the pathology, understand the deep venous component, understand the superficial venous component, that will allow us to treat the pathology appropriately. And for me, if there is a suprainguinal obstruction, treat that first and then treat the superficial veins. If there's a fempop obstruction, just treat the superficial veins. And if there's deep venous reflux, don't worry, treat the superficial veins. On top of that, I have liberal use of of ultrasound-guided foam sclerotherapy, but all need proper compression. And thank you very much.